Oh, hi. This is Ayo. This is my PowerPoint on case study number one. This is it's a 3-year-old engineering student from Japan that was referred to the mental health clinic after one of his professors found out that he was not making sense at all. He has become He's thinking that his room was bugged with listening devices and control machines by strangers. And these same strangers he thought were standing near his apartment a week before. He also believed that his classmates were mocking him, and he's been targeted by television reporters for his brilliant mind and his ambition to be Prime Minister of Japan one day. So, from what I saw in this patient, Mr. Daishi, I came up with a diagnosis, delusional disorder, the mixed type. Delusional disorders delusions are beliefs that are held by individuals that does not change even when presented with contrary evidence. And I think this is mixed because he had more than one uh, theme in his delusions. The first one was the persecutory type. That's because he believed that people were conspiring against him. Thinks that his friends are mocking him, that people are laughing at him, and all that, are trying to ridicule him, planting devices in his apartment. The second one is the grandiose type. This is where he believes that he has a brilliant mind and that he is going to be a future prime minister of Japan one day. Um, these symptoms have been present for the past 3 months, which kind of make me believe too that this is it warrants the diagnosis. I was kind of thinking maybe schizophrenia, but schizophrenia has to have been present um, in 6 months, and he doesn't have the other symptoms of schizophrenia, such as disorganized speech or thoughts. So my diagnosis was delusional um, disorder, basic, the mixed type. So also um, in this diagnosis, Mr. Dices is able to function well and he's well groomed despite his delusions and the impact he has on his schoolwork. He has no depression, no mania, or no history of psychosis. Also, there was no substance abuse, as was evidenced by his clean drug screen at the time of visit. So, for the treatment of delusional disorder, SEDOC and WIS, which is test for class, says that psychotherapy should be first treatment. Uh, so in psychotherapy, they advise for the establishment of trust, um, because if the patient does not trust you, uh, nothing, they will not believe you. They will not do anything with you. They just because of this nature of the delusion. Um, Psychotherapy should be individualized rather than a group. The sessions should be regular and the therapist should be punctual, all this in the aim of establishing trust. So another study that I did, what I saw was they studied the efficacy of individualized metacognitive therapy, MCT, comparing that to cognitive therapy interventions on patients with delusional disorder. So they found that with MCT, individualized metacognitive therapy, uh, the patients showed improvement in the delusional symptoms at 6 weeks, only at 6 weeks, but no difference at 6 months when they compared it with the cognitive therapy. So they attributed this uh, like difference to booster sessions. Cognitive behavioral therapy group, they had a lasting lasting improvement, and the authors believe that this is due to the booster sessions that were attached to this cognitive behavioral therapy. So they recommended that therapeutic materials be reviewed regularly after completing interventions also. And they want uh, more research comparing individualized metacognitive therapy and group therapy in the future research. Another study by Balsan et al. 2019, they conducted a study to assess the efficacy of extended sessions of individualized metacognitive therapy, MCT, and they said also with cognitive remediation, and they were targeting neurocognitive symptoms in patients diagnosed with schizophrenia, spectrum disorders, and delusions. So in this study as well, a significant improvement in the severity of delusions was found in those treated with MCT. So they recommend that future trials use larger sample size and that efforts should be made to ensure that those who assess the outcome measures should be blind to the group's allocations. So the study by Freeman et al. In 2016 compared virtual reality cognitive therapy versus virtual reality exposure in patients with persecutory delusional disorder. And they found that virtual reality cognitive therapy is superior to virtual reality exposure. And they recommended a lengthened treatment time to enhance the therapeutic effect. So Olmo, Mary, Learmount, and Cupers in 2016, they investigated the experience of family members who were taking care of patients with delusions. At the end of the study, they they just advise routine assessment of caregivers, just so that you we can know the possible risks that are associated with taking care of patients with delusional disorders. And so if we know the risk associated, then we can take better care of these patients themselves, because the patients with delusional disorders are really, hard to take care of. So if their caregivers need help, they should be able to get the help, and we should be able to offer interventions and support whenever they need it. This was very interesting to me. I just wanted to know what the family members of these patients think. It was a very, very small sample size that I was just curious, and I felt it was important to include, members or caregivers of these patients. So Peralta and Cuesta in 2016 studied the relationship between delusional disorders, paranoid schizophrenia, and non-paranoid schizophrenia to differentiate the characteristics of each of these disorders. And they found out that the only thing that these disorders have uh, in common is the drug abuse. Drug abuse is the only risk factor that's related to delusional disorders before the onset of illness when compared with gender and education. So the author recommended a strategy to identify those who are vulnerable to diminish the occurrences of delusional disorders. Skelton, Coker, and Tucker in 2015 compared the effectiveness of medications, antipsychotics, antidepressant and mood stabilizers, and psychotherapy versus placebo, or no treatment at all, or standard treatment with patients with delusional disorders. In this, they were very disappointed because they saw that there were no high quality randomized trials on delusional disorders. And so they felt that their review had very limited evidence and is therefore not generalizable. So they recommended further trials on delusional disorders. On psychotherapy, so treatment for pharmacotherapy, antipsychotics are reserved. Usually, they're they will refuse to take medications because of their delusions. They think you're trying to poison them. So antipsychotics are reserved for emergency situations when the patients become really, really agitated. So the providers should explain the side effects, what they're doing, make sure you explain what's going on, what you're doing, and the side effects of the medications. So otherwise they will think you're trying to kill them or poison them. Hospitalization only for evaluation to find the root cause of the delusion, and then also to so that if the patient needs to be assessed for their if they are trying to cause harm to themselves or to others, and then if the delusion is causing significant disruptions in the patient's social or occupational life, then they may need to be hospitalized according to standard rules. So the prognosis, patients with delusions are always resistant to treatment. Uh, so treatment is deemed successful if a patient with delusion disorder is able to function socially. They may still have the delusions, but at least they're able to manage the delusions, able to function, in their environments for work and for pleasure, for with their friends socially. So that is the end of my presentation. Thank you.